The following podcast is part of a certified educational activity titled Immune to the Impossible in Hepatobiliary Malignancies, Expert Insights on Breakthrough Innovations for Immunotherapy Platforms in Advanced Stage Disease. Access the entire activity and complete the post-test at peerview.com/AZW860. Downloadable slides are also available.
Hello, everybody, and welcome to this educational program, Immune to the Impossible in Hepatobiliary Malignancies. My name is Ghassan Abou-Alfa from Memorial Sloan Kettering Cancer Center, New York City, and I'll be discussing innovations for immunotherapy platforms, advanced stage disease. Let's begin with our educational programs and goals for today. Our goals for today are to make sure we learn on the frontline immune-based regimens that have been shown improvement, efficacy, and outcomes in patients with advanced hepatobiliary cancers. The novel strategies such as bispecific antibodies used alone or in combination with other therapies that are being explored. And cancer care teams should be prepared to address adverse events associated with immunotherapy platforms in patients with advanced ACC and biliary tract cancers as well. So to go on, we'll call for reinforcing new evidence of hepatobiliary malignancies, model solutions to address ongoing unmet needs. And to that matter, we have to please remember that liver cancer is unfortunately also on the rise. Worldwide, as we can see over here, there's more than close to 1 million patients with liver cancer back in 2020. And at the same time, we have unfortunately close to most of them, 830,000 that die from liver cancer. And if anything, there's a significant rise in liver cancer among young populations worldwide. And sadly, we're seeing also an anticipated increase in this number by an increase of close to 54% by 2040. Why is that? Because, of course, for many other risk factors, among which, of course, is standard, Hep B, Hep C, but add to it the morbid obesity and diabetes. And of course, with all of this, a lot of work to be done. We can no doubt, and we're delighted that we had the SHARP trial with the sorafenib that remains widely used worldwide. We have to please have it with a broad perspective regard to who really has access to what. But if anything, we also are concerned about the sequencing of the treatment options that remain a concern regarding second line, who's number one, who's number two. And of course, in regard to the new challenge expanding to earlier disease stages, i.e., local advanced disease, what shall we do there? How can we really even introduce the systemic therapy in the adjuvant or neoadjuvant setting as well? By the way, the story is not that different in regard to biliary cancers. And cholangiocarcinoma, carcinoma, as we can see over here, again, sadly, is on the rise. As we can see clearly, there's a continued worsening of the survival that is present, with only about 20% of the patients are alive at 5 years relative survival. And add to it, we can continue that there's a continued increase in the incidence as well. And with this, of course, we can see here that there's been a lot of advance regard to the therapy, which we're, of course, we're delighted about. As we can see, regard to first line, which we're going to spend a lot of time on, mainly it's checkpoint inhibitor-based therapy. And then, of course, in second line and third line, we have the targeted therapies that are more present and more prevalent in regard to therapy, even though, and albeit sadly, it really affects only few patients per se. Understandably, most patients are going to get the first line treatment, close to about 85%. By the time we're at really the third line, we're barely to about 70% that can get access to treatment. So that's why focusing on first line treatment, make sure we do the best we can, provide the best we can for our patients will make a lot of sense. So with this, to redefine our strategy to effectively manage HCC, and we'll start with HCC, the best practices on rapidly evolving evidence on immunotherapy platform. And for that matter, we remember that the BCLC staging, which has been really revised many times, among which the last one by Dr. Reeg has been great to really look into. We can see that sadly, patients still come at different stages of the disease, but more importantly, we can see that there's a certain alteration regard to how many patients present with the advanced stage versus the intermediate stage. And you can see here the advanced stage and really end stage disease sadly make quite a preponderance in North America, and compared to, for example, Japan, that has quite a bit of intermediate stage as well. And the 1 year survival, of course, will evolve. As we can see, intermediate stage will have close to 50% 1 year survival. But of course, stage C, which more advanced disease, 25%. And sadly, the stage D, which we don't want to go there, especially with worsening liver functionality, only 11%. So let's kind of take this perspective from a case, and we have a 64-year-old gentleman here with alcoholic liver cirrhosis, with a rapid eye quadrant pain. CT scan, as you can see, has shown a diffuse hepatocellular carcinoma in the left liver lobe. You can see this quite a bit. 10 centimeter in the diameter for the largest lesion with portal vein thrombosis. And the biopsy confirmed the presence of HCC. Very critical to get the biopsy, to need to know the disease with the grade 3, and alpha fetoprotein was 14,917, and the comorbidities including COPD and GOLD2. You see from the scan, it's quite extensive. It's not really like a subtle thing. And of course, we will start thinking with the portal vein thrombosis, what shall we do in regard to first line treatment of therapy? And of course, there's quite a bit of choices. This is incredibly positive news that we have so many opportunities for patients to provide from. And of course, if the patient is a candidate for checkpoint inhibitors, we definitely should do that. And as you can see, we're going to discuss about the atezolizumab plus bevacizumab, the durvalumab plus tremelimumab, which is called the STRIDE regimen, the new advent of the nivolumab plus ipilimumab, and of course, a single agent, also durvalumab or tislelizumab. Now, of course, if the patient is not eligible for the checkpoint inhibitors use, then the tyrosine kinase inhibitors, among which lenvatinib has been really driving quite a bit of the scene, and sorafenib will remaining a choice. So why are we talking about and why are we excited about the double checkpoint inhibitors or anti-VEGF plus checkpoint inhibitors? I think it's well represented by the AMBRAVE 150 study that looked into atezolizumab as the anti-PD-1 plus bevacizumab as anti-VEGF and showed improved survival 19.2 months compared to sorafenib 13.4 months. The Himalaya study, on the other hand, combination of two checkpoint inhibitors, an anti-PD-L1 durvalumab plus anti-CTLA-4 tremelimumab, combination of the two, 16.4 months compared to sorafenib 13.8. And of course, you start wondering, like, okay, wow, one looks better than the other. Please, please be careful. We always have to, when look at data like this, look at the demographics. Patients differ in regard to etiology, patients differ in regard to outcomes, and as such, the numbers might really differ, even though they are not necessarily different at all. And I'll carry on with that in a second as well. And here to that kind of same matter, we have newly the Checkmate 9DW, which looked into first-line nivolumab plus ipilimumab. Intriguingly, it showed the survival up to 23.7 months in favor of the nivolumab plus ipilimumab compared to the choice of the trader's choice. Like, whatever the physician and the patient decide, lenvatinib or sorafenib, mostly were lenvatinib, but still 20.6 months. You see here already we're getting a sense about the 13 months that we saw with the atezolizumab for the sorafenib, and now we're 20 months or so for lenvatinib. Tells us that there's more other variables that really come into play to really tell us about the combination therapies that we're talking. The good news is that all those three options of therapy are available and they are already all FDA approved and also approved by other agencies worldwide as well. And by the way, we can really claim that we're doing comparison, but we should not. But nonetheless, if we line them up over here, we can see that the three choices are really not much different per se, because as an example, to give you a sense of this, with the atezolizumab plus bevacizumab, most patients were Hep B. And interestingly, we know that Hep B patients will always fare better to, to the benefit from the checkpoint inhibitors, even though there could be other variables. And especially when it comes to the Checkmate 9DW, the number of patients with Hep B were similar to the Himalaya study, which make us really show that there are other variables coming to play over here. But if I were to really say anything today, I'll tell you, they'll all pretty much work the same way. You probably start dependent more on certain advantages that's coming on from comfort, experience, tolerability, and of course, how much of a workup that needs to be done. For example, with atezolizumab plus bevacizumab, and it's very important message to relate to all of you, scoping, very critical. Want to make sure that patients are scoped to make sure that if there's any endoscopies that show varices, we should avoid the anti-angiogenic like the bevacizumab. On the other hand, convenience, like durvalumab, Tremelimab is given only once in a lifetime. Amazing, like one drug, once in a lifetime, and that durvalumab is given on a monthly basis. So, of course, from now on, you can see that things might differ in choices and preferences based on convenience and other components as well. And by the way, we're not even done because, if anything, the advent of the KER310 therapy was camrelizumab plus rivaroxabanib, again, anti-PD-1 plus anti-VEGF, showing an incredible improvement in survival, as you can see here, 23.8 months compared to 15.2 for sorafenib, in favor, of course, of the camrelizumab plus rivaroxabanib. Also, an improvement in PFS, one of the probably best PFS that we've seen. Again, one more time, this study was mainly in Hep B patients. About 75% patients were Hep B because it was done in China. But again, this kind of going in the right direction. I will not be surprised that will be approved at some point in time. Over here, not necessarily a perfect picture comparison of all of them, but at least the two key players which already are in the market, which is the Ambrave 150 and the Himalaya, i.e. atezolizumab plus bevacizumab and the durvalumab tremelimab, because see clearly here regard to adverse events that they might probably differ a little bit, but intriguingly we can see that, for example, in regard to certain components like hypertension, understandably it's more on the bevacizumab because, of course, because of the bevacizumab. On the other hand, we can see that diarrhea is relatively more present in regard to the anti-CTLA-4. Intriguingly, though, not to the extent that anybody would have expected, way better than we thought. And in general, these therapies are very well tolerated. Fascinating thing, though, that we have noticed that patients who actually get some adverse events, not that we wish them for everybody, will actually prove on the durvalumab plus tremelimab to fare better, actually almost doubling the survival. It's incredible data that already was published as well. And by the way, one component that we always come to question ourselves on, can we use the therapies even in patients with more advanced liver functionality? And the Sierra study, brand new, that we are very proud to have reported at the ESMO GI 2025 in Barcelona, has shown that in a phase 3b, that durvalumab plus tremelimab in patients with advanced HCC, i.e. with the child-pugh score B7 or B8, have really got the therapy, and they looked into the outcome from it in regard to tolerance plus survival, and the therapy was actually rather very, very encouraging, as we can see over here. And we can see that the adverse events were really still within the same confines, no difference at all compared to what we have seen in regard to the durvalumab plus tremelimab, and of course among the different categories of the patient child-pugh scoring as well. And where is this all coming from? What are we trying to do over here? This is a fascinating component that really look into the anti-PD-1, anti-PD-L1, which you can see it's in yellow and blue to the extreme left on either of the pictures. And then what we can do is try to kind of like marry it to some kind of further binders or further enhancers, among which they're like, the anti-CTLA-4. And also we can see that other component, among which TIGIT has been quite fascinating. As you can see, it's a really a robust binding that really will make a strong binding to the T cells against and fighting the cancer cells. And no doubt that we're very intrigued by, and we'll tell you some data on, show you some data on the anti-TIGIT plus anti-PD-1, anti-PD-L1 as well. And to that matter, actually, perfect timing is a Gemini study that interestingly studied the combination of the volstromic, which is again a bigemini, and it's include anti-PD-1 plus anti-TIGIT and therapy plus bevacizumab, as well as plus the lenvatinib. And we looked into all the double combinations, the quadruple of combination of, and we did this also in biliary tract cancer. But let's focus first on the uh, part of the study in HCC, which I'm humbly and proudly one of the three leaders worldwide for the study, including China and Japan, other than the United States. And the study have been already shown some intriguing first continued accrual and enhancement of accrual, but we don't have data yet. So just stay tuned. We'll let you know one day. And back to our patients, you remember, with the tumor. And now that we have that many choices of therapy, we have to remember one thing over here, that the etiology might differ, might impact choice of therapy, but we cannot really make a decision based on that yet. On the other hand, in regard to the varices, which could be there, and if anything, let's say the patient had grade 2 varices, and with especially with the main port vein involvement per se, I probably will avoid the atezolizumab plus bevacizumab. We have robust, great therapies otherwise, and durvalumab, tremelimumab will be appropriate as well over here. Could also be possible that we do something else. We can, like for example, durvalumab single agent. We can, but I think the comfort zone in regard to durvalumab, prostamab has been evolving quite a bit. Ipilimumab, nivolumab is a little bit newer into the market, so we're still not sure about the experience yet with it 100%. And in regard to the other choices, as we said, either we cannot do it like atezolizumab plus bevacizumab because of the concern with the varices, or of course, in regard to reversal plus camrelizumab, not approved yet to use. But by all means, I think we all agree that there's no concern at all here to use durvalumab alone or tislelizumab alone. We can definitely add on the very robust tremelimumab that, interestingly, and give you a fascinating point about that, tremelimumab itself is actually 3 times more potent than CD28, which is our natural phenomenon to enhance CD80 and CD86 that send the message to the cells to really make the anti-PD1 work or exert its effect. So you have a drug that's even more potent than the natural phenomenon that we have in our body, and then benefit for the treatment for the patients. And one more time, in regard to the adverse events, please, this is more of an important message. Other than the concern of diarrhea and, of course, monitoring, even though I showed you data that's not necessarily that much of concern, please remember always, and this is what I do in clinic, I'll check on the thyroid function on a regular basis for the patients, actually at every therapy, which is once every month, which is not that inconvenient for the patients. And I'm sure that really there's no concern regard to any thyroid alterations regard to therapy. Number two, I also make sure that I check on the blood sugar to make sure that there's no alteration got to the pancreatic function. And please, encourage patients always anything they don't like. Joint pains, rashes, always let them talk to you. At least you can reassure them, or you can bring in something of concern per se. And by the way, the guidelines of the NCCN will support what I just mentioned. As you can see here, considering endocrine consultation early in the game. Of course, if there's alteration in regard to the TSH, D34, cortisol level could be important. By all means, initiating thyroid hormone supplementation. You can do it on your own, but if you want to get involved, the endocrinologist will even be better. And repeat TSH, I said myself, I do it at every sequence. Well, makes sense because you don't want to bring the patient in the middle of the sequence, because every 4 weeks will be perfect, like, for example, with the durvalumab plus tremelimumab. And of course, ultimately, if there is, God forbids, an adrenal insufficiency, you would have to deal with it as well. And by the way, this is like a little bit bigger picture. This is inspired that we are really at that point in time in regard to the whole thing happening with HCC. Remember, this table was empty at one point in time. Then we had sorafenib. Look where we are. Atezolizumab plus bevacizumab, durvalumab plus tremelimumab, ipilimumab plus nivolumab, all three approved. Camrelizumab, brivaracetam, hopefully coming soon. Sorafenib, vatinib. And even though we're not talking about it today, but please remember that in second line we have regorafenib, cabozantinib, ramucirumab, pembrolizumab, and third line even we have cabozantinib as well. Interestingly, as you can see, sorafenib, vatinib, let's say we use the atezolizumab, bevacizumab, or durvalumab plus tremelimumab, or this triad regimen, as we called it, in first-line therapy. What do we do with them? We just forget about them? Not really. As you remember, I brought in back in 2020 the concept of line-1 therapy, i.e., you can downgrade or you can upgrade the durvalumab, tremelimumab to first line, and you can downgrade sorafenib to second line, and you can use them as well, because they are great entities and definitely important to make sure the patient use those assets before we declare them. Now they really don't respond to them at all because you never tried them per se. So a sequence will be, as an example, durvalumab, tremelimumab, followed by lenvatinib, followed by cabozantinib, as a classic scenario as well. So with this said, we kind of like move on to where we are going to biliary tract cancer. A lot to talk about over here, especially the immunotherapy paradigm in biliary tract cancer is continuing to evolve with emerging roles for the immunotherapy platform advanced disease here. We'll start with the case again. 60-year-old gentleman with the history of abdominal pain and unintentional weight loss. Metastatic intrahepatic carcinoma is noted on imaging. Good performance status. No relevant biomarkers detected. Of course, here, this is like a scene of the whole story, what we can do. We have, in combination with the GMC cisplatin, which is like the core, which has been placed with and dependent on since the ABC02 study. And with it, we can use either durvalumab or pembrolizumab based on which data you follow. And of course, in regard to other recommended regimen, plenty of variation of in regard to FOLFOX, gem-nab-paclitaxel, gem-capsidine, gem-ox. It's very important. We're going to talk about that in a second. And then lastly, you can see that over here, the use of checkpoint inhibitors by itself, if you have a TMB high, could be also an appropriate option. And of course, if you have any other alterations, among which the NTRK or the RET, you can probably continue on the targeted therapy as well. But of course, the majority, as we can see over here, are going to be dependent on the checkpoint inhibitors, being durvalumab or pembrolizumab, plus the gemcitabine cisplatin, plus, as you can see, some other alteration of chemotherapy, which we'll talk about as well. Here, the Topaz 1 study, we spoke quite or referred to already quite a bit of time. If anything, it is in patients with advanced biliary tract cancer, durvalumab plus gemcitabine plus cisplatin, with the gemcitabine cisplatin given for 6 cycles, same as the ABC02 study, plus following with durvalumab single agent, versus the gemcitabine cisplatin plus placebo for 6 cycles, followed by placebo afterwards. I have to admit that nowadays we're seeing that probably keeping on some chemotherapy will be appropriate. Interestingly, we start practicing this even before any advent of data, and we'll talk about that in a sec. But more importantly, we can see here that the continued survival is continued to be reported and improved. And here we can see that at landmark analysis of at least 3 years, we already have about 15% of the patients alive versus close to 7% on the chemotherapy alone. And more importantly, that the high 36 month survival rate is also commensurate with a continued response. As you can see over here, we can see clearly that the response rate and survival improvement continue to do great. As you can see, we have CR and PR up to 1/3 of the patients, incredible at 3 years, and stable disease in about 10% of the patient as well. Adverse events, understandably, please remember some of it coming from the chemotherapy component, some of them coming from the checkpoint inhibitors, but in general has been rather very acceptably okay. And remember, please, chemotherapy, especially the cisplatin, probably we're going to really get rid of after 6 months, and we'll explain why in a second. By the way, and this is really where I'm going to talk about those more, the Keynote 966 study, gemcitabine cisplatin plus pembrolizumab. Again, same scenario, but interestingly, they kept on the gemcitabine after the 6 months and continued it with the pembrolizumab. Quite fascinating, and ironically, as I said, we've been using this already with the durvalumab plus the gemcitabine cisplatin with the Topaz 1 study and carry on with the therapy even after the 6 months. Why is that? Because here, again, one more time, improvement to survival in regard to the Keynote 966 with pembrolizumab plus gemcitabine cisplatin with 3-year survival up to 13%. I wouldn't really compare numbers here. It was a tad better with the durvalumab gemcis. It's not necessary to compare per se, but it tells us yet, yes, there's a big need for the continued of the chemotherapy as well. Why is that? Remember, those tumors are cold. They're not really hot, same like the checkpoint inhibitors used in liver cancer. As such, intriguing the tumor further with chemotherapy will be appropriate. The guideline will use the gemcis only for 6 months with the durvalumab. I'm giving you my personal with the durvalumab correction with the gemcis, but I'll give you my opinion. I would probably keep the gem alone with the durvalumab every 3 weeks once. Safety profiles over here, same thing. However, there was a concern. There was like some more death, as you can see here, especially on the placebo gemcis, about 10%, 6% for the gemcis plus pembrolizumab. And here to go back, you remember we spoke a little bit about that in the beginning. What if I don't like to use gemcitabine cisplatin? I want to use something else. Into the tourmaline study, we probably just reported it again at GI ESMO in Barcelona just last July. Has here clearly a different combination, as many as you want, of the chemotherapies that you really might feel comfortable with or you have access to, among which the gemcitabine cisplatin, gemcitabine oxaliplatin, gemcitabine carboplatin, gemcitabine S1, and gemcitabine nab-paclitaxel, you name it, you can really think about it, you can try to use it. And interestingly, over here, we continued after that with durvalumab. And interestingly, we have seen that the results really did not matter much. All of them did benefit, as you can see over here, which continued benefit no matter what combination you have used then in regard to responses as well. Safety profile did not matter much. If anything, of course, with the more intense platinums like oxalipan, cisplatin, you'll be a little bit more conscientious of, but ultimately, because of the limited exposure to the platinum, it will not be that of much of a concern. And by the way, here, just more of a sign. I know we're all excited, and we should, about the multiple targeted therapies that really can be applicable for biliary cancers. And it's very important, as always, you heard me many times saying, patients should have their checkpoint, they should have their uh, targeted potential therapies, i.e., their genetic testing for the tumor done even before they check, even with the doctor. But please remember, these are rare. Ultimately, we can see over here that the potential for IDH2 is like 4% only. In regard to FGFR2, about barely less than 10%, IDH1, 14%. So this all also come in second line therapy, not in first line yet. For that reason, the excitement is more about the use of checkpoint into the first line therapy. Check for those potential opportunities. If they are really truly applicable for your patient, by all means, they will be available for you as well. And here, just as a sense of that, I'm not celebrating the great effort that we did here at Memorial Sloan Kettering Cancer Center, New York, but of course, pemigatinib, and also give credit for the work that was done by our colleagues in regard to futibatinib, are great results, including sometimes even complete response. In regard to the Clarity study that we proudly also led from Sloan Kettering, in regard to the anti-IDH1, ivosidenib showing an improvement in survival as well. And of course, also thanks to the work that was done also here at Sloan Kettering by my colleague Jim Harding in regard to zanidatamab and HER2 amplified biliary tract cancer, also showing great response, among which even the CR. And this year we see also for the zendatinib also improvement in survival as well. So, quite we're going on. Back to our case of the gentleman with the biliary tract cancer. If anything, first line therapy, I would say chemotherapy choices, would not really matter much in regard to what we saw with the tourmaline study, but make sure the checkpoint inhibitor is being used. Of course, check on the potential targeted therapy in case you need down the road. And of course, hopefully, your patient will carry on for long, long, long time on the checkpoint inhibitors with at least single agent gemcitabine or none at all, and hopefully will benefit and not use second line therapy with, as we saw, the complete response that we reported, for example, with the durvalumab plus gemcitabine plus cisplatin. So with this, I leave you with the following messages. Please, incidence is on the rise. Make sure you are aware, make sure you're up to date in regard to hepatobiliary cancer and what are choices of therapy. Number two, checkpoint inhibitors are the main driver for the HCC, and definitely our main driver in regard to biliary tract cancer HCC in combination with chemotherapy. Understandably, the adverse events can be there. Please keep an eye and be aware of. And anything you are not sure of, always check in. And always, I tell all the patients, anything you don't like, call. Because if anything, we can see that the monitoring of the checkpoint inhibitors adverse events can be early in the game more beneficial for the patients. And more important, as we said, patients with some adverse events might even benefit more from the therapy. Not that we wish it for, but of course, it will be appropriate to monitor it as such. And of course, the targeting of the targeted therapy in hepatobiliary cancer and second line options, leave it as second line option. Tyrosine kinase inhibitor in regard to ACC, the targeted therapy or the biologics in regard to second line for the biliary tract cancer. Of course, great that we're talking about second line therapy, but the main bulk remain checkpoint inhibitors in first line. I thank you again for joining and participating in this educational program on advanced hepatobiliary cancers. Please remember to download the slides, and they are all yours. And there are other resources from peerview.com to use in your clinic. I hope they find this session informative and useful for your practice. Thank you for joining.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/AZW860.